My name is Sarvini and my supervisor is Dr. Tiba. Today my CB topic is going to be about approach to intra-abdominal injury. So first of all, okay, this is the outline for my presentation today. I'm going to talk about anatomy of the abdomen, mechanism of the injury, and location of injury, assessment and management, investigation, algorithm to surgical versus non-surgical intervention, and also take-home message. So first of all, let me explain regarding the anatomy of the abdomen. So anatomy of the abdomen, we can divide into 4 parts: anterior abdomen, thoracic abdomen, flank and back. Anterior abdomen is from costal margin superiorly, inguinal ligament and pubic symphysis inferiorly, with anterior axillary line laterally. The contents are hollow visceral organs, such as small bowel and also large bowel. While thoracic abdomen is from inferior to the nipple line anteriorly, infrascapular line posteriorly, superior to the costal margin. Contents are diaphragm, liver, spleen, and stomach. While flank, in between anterior and posterior axillary line from 6 intercostal space to the iliac crest. Content are usually retroperitoneal organs. And back is posterior to the posterior axillary line from the tip of the scapula to the iliac crest. Content are also retroperitoneal organ as well. However, the musculature in flank, back, and also paraspinal region act as a partial protection from visceral injuries. As you can see, there are 3 types of mechanisms of injury: blunt, penetrating, and blast. Example of blunt injuries are direct blow and also sharing injuries. Direct blow usually happen in car accident where the person hit direct injury to the steering, while sharing injury happen when a person wearing a seat belt and fall against the seat belt, causing sharing to the hollow visceral organs at the anterior abdomen. Blunt trauma forces actually can deform the solid organ and also hollow organs, which can cause rupture with secondary hemorrhage and also contamination, which lead to peritonitis. Example of penetrating traumas are stab wound and also gunshot wound, which can cause tissue damage by laceration, cutting, and most commonly injured organs are in penetrating trauma are liver and also small bowel. As we can see, organs most frequently involved in blunt trauma are solid organs, which are liver and also spleen. While in stab wound, liver and also small bowels are most commonly injured intra-abdominal organ. And in gunshot, usually small bowel and colon and liver are the most commonly injured intra-abdominal organs. So usually the patient with intra-abdominal injury will present to the ED with complaint of abdominal pain, hypotensive due to severe bleeding, and also peritonitis due to contamination in the abdomen. In physical examination, we might find marks such as belt and also staring marks and bruises upon inspection, and abdomen might be distended, and patient might have localized and also generalized tenderness or rigidity. On auscultation, there can be a bowel sound at the thorax if there is a diaphragmatic injury. And we can also find if there is an instability of the lower thoracic cage, it indicates the potential for splenic and also hepatic injury. Moving on to the location of the injuries. As I mentioned before, solid organs are the most common organs involved in blunt trauma, and these are the signs that can be presented in solid organ injuries. Gray Turner sign is a bluish first of all, let me explain about the Gray Turner sign. Gray Turner sign is a bluish discoloration at the lower flank and lower back, usually associated with retroperitoneal bleeding of the pancreas, kidney, and also pelvic fracture. While colon sign is a bluish discoloration around the umbilicus, indicates the peritoneal bleeding, often due to peritoneal hemorrhage. And Kerr sign is a patient complains shoulder pain while in supine position. It indicates the diaphragmatic irritation caused by splenic injury, free air, and intra-abdominal bleeding. While balance sign is actually dull on percussion at the left upper quadrant is a sign of splenic injury. And we can also find, which is very rare actually, but we can also see seat belt or London, or also called as a London sign as well. It shows that the severe impact of the force during the trauma. In hollow visceral organ injuries, patient might present with blood loss due to mesentery injury. Other than that, patient also might complain of might have peritoneal contamination due to perforation of the stomach, small bowel, and also large bowel. So the mechanisms and suspected organ injuries are like in penetrating trauma, as I said before, in penetrating trauma, small bowel and colon are the most common organs that can involve. And in deceleration trauma, usually in deceleration trauma, we can find bucket-handed tear of the mesentery. So this is the example of the picture. It shows that bucket-handed tear of mesentery. Retroperitoneal injuries. Retroperitoneal injuries are very difficult to be diagnosed, as the signs and symptoms are very subtle and also might absent at the initial presentation. So it's quite challenging to diagnose at the initial part. So the retroperitoneal organs are kidney, adrenal gland, aorta, inferior vena cava, duodenal, pancreas, ureter, ascending and descending colon, esophagus, and also rectum. So as I said before, in retroperitoneal injuries, it will take hours and also it will take hours to become clinically apparent. So patient might present with clinical presentation of abdominal pain, fever, nausea, and also vomiting. So diaphragmatic injuries usually are insidious and also occasionally obvious. When bowels in diaphragmatic injuries, we can hear bowel sound. Bowel sound can be auscultated in the thoracic cavity. So once when we do chest X-ray in a patient who presented with diaphragmatic injuries, usually in chest X-ray, what are the things we can find is inability to trace the normal hemidiaphragm contour, intrathoracic herniation of the hollow viscus, and also left hemidiaphragm higher than right hemidiaphragm. And most importantly, the nasogastric tube will be coiled in the thorax. So moving on to the very important part of today's topic, assessment and also management. When patient present with intra-abdominal injury, we must do first of all we must do a primary survey, which contain of A, B, C, D, and E. A is we will look for airway patency. We will look for any airway noises or foreign bodies in airway. B is breathing, which we will look for respiratory rate, any added sound, and also symmetry movement of the symmetry of the chest movement, and also any tracheal duration. While circulation I will be explaining in detail later on. Disability, usually we will look for GCS score, and exposure we will do an examination from head to toe examination. And secondary survey is about complete history and also physical examination. So in circulation, we must first of all assess the circulation status like pulse rate, pulse volume, whether patient is pink or pale, and then capillary refill time, BP, and also pulse rate. If patient is hypotensive, if patient is hypotensive, we have to rapidly identify the cause of the hypertension, whether it's an abdominal or pelvic injury that causing the hypotension. So this is the sign and symptom of the hemorrhage by class. So as you all can see, in class 1, blood loss will be about less than 15%. So the vital signs will be normal. While in class 2, the blood loss will be 15 to 30%. Patient might have mild tachycardia and also with no any other vital sign abnormalities. In class 3, patient will have markedly blood loss, will present with tachycardia, tachypneic, and also reduced urine output. Lastly, in class 4, with severe blood loss, patient will be even more tachycardic, tachypneic, and also reduced in urine output. So both in class 3 and class 4, patient need urgent blood transfusion, but in class 4 need even more urgent. So what we have to do is, first thing we have to do is insert two large bore granular together with taking important blood investigation and start fluid resuscitation. So we can resuscitate the patients with 1 liter of isotonic crystalloid for adults and 20 milliliter per kg for pediatric patient. After that, we will assess the patient's response to the fluid resuscitation and identify evidence of adequate end organ perfusion and also tissue oxygenation. These are the responses to the initial fluid resuscitation. When we resuscitate, patient with minimal blood loss, which is about less than 15%, patient will respond rapidly, which means that the vital sign will back to normal rapidly. So the need for operation also blood is possible. However, in transient response, the vital signs will be transient improvement with recurrence of decreased blood pressure and also increased heart rate. And the need for blood is moderate to high. However, when patient with a minimal and no response, the vital signs remain abnormal, the estimated blood loss is severe. Thus, the need for the blood is immediate and the need for the operation intervention is highly likely. Moving on to the investigation that can be done in intra-abdominal injury. So the first we can do is FAST scan. It's called FAST scan. It's a primary diagnostic study. So it can rapidly identify the free intraperitoneal fluid. There are 4 areas that can be seen There are 4 areas to look for the presence of free fluid: hepatorenal, splenorenal, pelvic, and also pericardium. So this is the free fluid example of the fast scanning result. This is liver, this is right kidney. It's actually hepatorenal access. And then this one is the spleen, and this one is the left kidney, is a splenorenal access, and also this one is the pouch of Douglas, and this is the pericardium. Other than that, we can also do a chest x-ray and also anterior posterior view of pelvic x-ray. In chest x-ray, it is helpful when patient with diaphragmatic injury, which will show herniated abdominal content in the thoracic cavity. While in pelvic x-ray, it helpful to identify the pelvic fracture. The most important investigation that should be done is CT abdomen pelvic. It is a non-invasive gold standard study for the diagnosis of intra-abdominal injury. So the major advantage is about CT scan is the precise location and also grade of injury can be identified. So it can also quantify and also differentiate the amount and type of free fluid in the abdomen. Another one is a diagnostic peritoneal lavage. This is not practicing anymore, I guess, because of the wide availability of a CT and also ultrasound at ED. But however, for our knowledge, diagnostic peritoneal lavage is considered positive if more than 10 milliliter of raw blood is aspirated immediately. So surgical versus non-surgical intervention. So if patient is presenting with blunt abdominal trauma to the ED, the first thing we have to do is abdominal examination. we must rule out whether the patient is having peritonitis or not. If there is a peritonitis, it is an emergency situation where we have to send the patient for exploratory laparotomy. If there is no peritonitis, we can send the patient for CT scan. And in CT scan, there are three things that we have to look for: whether the patient is there any hollow organ injury, solid organ injury, and also free intra-abdominal fluid. So if there is a hollow organ injury, we will send the patient for exploratory laparotomy. If not, we will observe the patient. If there is a solid organ injury, if the solid organ injury, example like splenic injury grade 4 and grade 5 and pancreatic injury, we will consider for exploratory laparotomy also. If not, we will consider non-operative management. And if there is free intra-abdominal fluid and the fluid is in large amount and patient has abdominal tenderness and abdominal vital sign, we will consider exploratory laparotomy. Other than that, if in case patient doesn't have any complaint and also there is no free abdominal fluid, free intra-abdominal fluid, we will proceed with the serial abdominal examination, monitor vital sign, and also repeat laboratory tests. So the take-home message is early consultation with the surgeon is necessary for a patient with possible intra-abdominal injury. The assessment of circulation during the primary survey include the early evaluation for possible intra-abdominal and also pelvic hemorrhage in patients who have sustained blood trauma. Significant blood loss can be present in abdominal cavity without a dramatic change in the external appearance and all dimension of the abdomen, and also without an obvious sign of peritoneal irritation. A suspected intra-abdominal injury patient in hemodynamically unstable and presence of peritonitis need an emergency laparotomy. So these are my reference. Thank you. Any question, boss? Any question?